this week on the BackTable podcast.
I think if there's two main goals. The one goal is stop the trigger. So you may have endometriosis throughout the pelvis. I think of dried tinder on the bottom of the forest floor, right? But if I never drop a match on it, you may never have pain from it. And so the match is when the progesterone drops and your period starts. That is the match. And that's the trigger. So if we can stop that trigger, we can oftentimes stop that pain. The second portion of this is if we can hold us in the luteal phase as opposed to the follicular phase of the cycle, in the follicular phase when you have the most endometrial growth. And the endometrial growth is more or less stabilized in the luteal phase, right? In day 14 to 28. So if we can keep ourselves in that phase, which is essentially what a birth control does, estrogen or progesterone, everything, any contraceptive with the exception of an IUD.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, along with my co-host, Amy Park. Amy, how are you?
Good. How are you?
Good. We got to catch up a little bit today before the show because our guest, a good friend, had some technical difficulties. So it's actually nice that we had a few minutes to catch up. But we have a good friend, fellow colleague of yours, right? In Cleveland for a time, I believe. And
yeah,
a fellow Kentuckian, Dr. Mark Dassel. Mark, welcome to the show.
Thank you. Thanks so much for having me here, and love hanging out with both you guys when we get the chance. So this is just another chance.
I didn't know you were from Kentucky.
Oh yeah, go Cats! Yeah, absolutely.
We went to the same med school. You were a year behind me. Is that right?
1 year behind. Yep. Always following the more accomplished Mark. 1 year behind.
Yeah, right. No, that's exactly right. Don't you? Amy's laughing. So whatever you think.
No, I get it. Dasselhoff. Don't get in the way. I need a Mark sandwich.
No sandwiches today. Just good friends getting to hang out with each other. Mark is a minimally invasive gynecologic surgeon at Intermountain Health in Salt Lake City, and you're here today to talk to us about surgery for chronic pelvic pain, which is something I am excited to hear about, and I'm sure our listeners are going to be interested to hear about as well. But as we like to do at the beginning of every show, I want our listeners to get to know you. So tell us a little bit about how you got to be where you are in your career.
I kind of grew up California, Colorado, and then moved out to Kentucky for sort of middle school, high school, and did undergrad, medical school, all in Kentucky. So became obviously a Wildcat fan, where I met you, obviously Mark, and then from there wanted to come out west again for residency, and I was at the Phoenix Integrated Residency in OBGYN, which is now the Creighton Residency in OBGYN out in Phoenix, Arizona, and then got drawn back to Kentucky. I was lucky enough to work with Dr. Paya Pasic, John Reinstein, Lori Warren, and a lot more to name, but wonderful group in my fellowship. And my first job out of fellowship was at the University of Utah. Then came out and joined Dr. Park in Cleveland Clinic. Hung out there for a few years. Now back in Utah again, Intermountain OBGYN, where I specialize in endometriosis. I really became passionate about pelvic pain when I joined fellowship. I was lucky enough in residency to hang out with Dr. Hibner, who's a big name in chronic pelvic pain, right? And in the AEGL as well. And lucky enough to learn a lot from him. I didn't catch the bug when I was with him in residency, but when I was in fellowship, I just started recognizing when we were treating all those women with endometriosis that there was sort of a lot more to this than the surgical aspect of chronic pelvic pain. And so now I'm kind of where I am, built this practice here based on chronic pelvic pain, endometriosis, other, minimally invasive gyne surgical stuff.
Well, it is a complex specialty, and my entire practice is not pelvic pain. Thankfully, no, I think there is, the fellowships in MIGS certainly were, and maybe they're less now, they were highly variable. Some were really surgical, like you just never saw a clinic. Some were big on, I think Michigan, where I trained, was a lot of ambulatory, a lot of medical management of things. Some really big on fibroids, some really big on endometriosis. I think there's now some sort of expectations that they're all a little more similar. But Louisville, you guys did a lot of endometriosis surgery, right? I know Paya and Laura and those guys. A lot of complex endo, right?
Absolutely. And that's, I was so excited about, the deep infiltrating endometriosis surgeries. And I think that's what was, I remember really well in fellowship once getting to do a bladder nodule. And that was, bladder nodules are the best, right? You take them out and make this huge hole in the bladder, you sew them closed, they heal so well, and the patients do so well afterwards. Not the same with every endometriosis surgery where it's that cut and dry, but definitely got the bug for that difficult deep endo out in the retroperitoneum, and I love doing it, love teaching it.
No, I think that's one of those things that, as far as what I do, it's the hardest thing, I think, in my work, and I think in our specialty, this DEI, the deep infiltrating endometriosis, and really the challenging cases where the surgical planes are just not obeyed by this disease. It goes where it wants. So you went out to Utah initially. You were doing OB and GYN, sort of start trying to build, in a sense, a MIGS practice, and then give up OB when you came back to Cleveland?
Right. Absolutely. And it was a very back in my day type situation. Back in my day, there weren't so many jobs for minimally invasive gyne surgery. And, I think a lot of us didn't necessarily want to jump into OB. I was one of them, but the job at University of Utah was a great offer, and I could do MIGS, but I, was still doing OB. I enjoyed that. It was a fun start to my career, but it takes away from really wanting to dig in and specialize on something else when you're sort of, split halfway. And I think it's given me a lot of I don't want to say empathy, that's a little bit, but I've just recognized what other OBGYN subspecialists, when you're doing both OB and GYN, how you're torn in so many different directions.
When you were there, was Angela Chowdhury there too?
She left the year before me, but I was able to connect with her. Someone knew when she was leaving, connected me with her. And that's actually how I met her first, when we were talking about that job at University of Utah. She's wonderful.
Because I was going to say, I'm like dating myself here, but my career has spanned the rise of MIGS, like training at McGee. People did not understand what MIGS was. Like TED came, in 2001. I started there in 2002. Suketu was a year or two ahead of me in residency in Suketu, Mansouriya. And then the fellowship started then, and then McGee trained all these people, and the pelvic pain became like a big flavor within MIGS, which I think you guys are going to change your name probably to, what is it, complex gynecologic surgery or something like that.
I think so.
Yeah, but what do you think makes the endo? There's so much overlap in the Venn diagram between the endo and the pelvic pain and the fibroids. So what do you think really is a differentiator for the pelvic pain? Is it the central visceral kind of stuff that you and Ashley are talking about all the time? Or what do you think are the specific skills that you impart when you're talking about pelvic pain? You know what I mean?
Yeah. Well, I think one is the selection of the diagnostics. And number one, that very first time I meet a patient and the detailed history and the detailed exam, that takes longer and requires me to fight admin a little bit more to give me a little more time. But, finding out sort of all those things from the beginning, like what, bladder dysfunction, yes, but why? Is it interstitial cystitis? Is it a nodule of bladder endometriosis? Is it recurrent UTIs? And then does this look like this could be a surgical issue? So much of what we see in the chronic pelvic pain world, I think, is the same symptoms that can be described by different etiologies. For instance, like deep infiltrating endometriosis, most common symptoms of deep infiltrating endometriosis of the colon, the colorectum, are going to be constipation and pain with bowel movements, especially non-cyclic, so not necessarily always with the period, right? And so those are the most common, but they're also present in women who have pelvic floor tension myalgia, or also high tone pelvic floor, levator spasm, whatever you want to call it. And I think a lot of it is trying to find all of the causes of the pain, trying to broaden that differential, and then trying to narrow it back down with things like imaging, with things like exam, and then sometimes surgery as well.
I think that also when not to operate and when to do the medical management is a huge piece. for you, and then also the endless empathy and patience and like the resources of having like a care coordinator and nurse triage and all the things like an NP to manage all this non-surgical stuff. Like, how do you muscle all that stuff together, like to convince your administration that this is all necessary, and the pain psychologist, you know what I mean? I'm just like pelvic floor PT, whatever. It takes like a village, right?
Absolutely. And I think a lot of medicine, we talk about patient care as being number one. And, and I think in a perfect world, patient care is always number one. But in a perfect world, there's no number two. But there is a number two, because we live in a society where the lights have to stay on. And, it can be difficult to convince your institution that it's worth spending money on certain things, chronic pelvic pain being one. It may take 4 resources where something a MIGS surgeon does, like say we talk about fibroids. It takes a lot fewer resources to address, typically at least, fibroids, abnormal uterine bleeding than it does chronic pelvic pain, with the multiple resources that are sort of necessary, including exactly as you said, but the major ones being organizing care, pelvic floor, the psychology, and not to brush over that, because the psychology of being in pain for 20, 30 years, that obviously requires a lot of barriers pop up to the easy treatment plan. And so I think that one of the major ways that, and if I had this down perfectly, I'd probably be making a lot more money, but a big part of this is that we need to look from the other end, that the sooner we're able to treat these patients with chronic pelvic pain, the fewer resources that they will need in the long run. And so I think that's the way that you convince that you convince your administration that this is a worthy project, even though initially it may look like it costs more money from the outset.
Well, it also depends on where you're spending the money too, right? If you have one person doing it all, based on how reimbursement is set up in most institutions, it looks like you may not be as productive seeing a smaller number of patients and slower clinic visits, but ultimately those are patients that need to be seen. These are patients that have significant clinical issues that would then just be spread into other people's clinics, right? So people who could be seeing a ton of OB patients or routine GYN, that it then is disruptive across the entire department, as opposed to one person who specializes in it and hopefully does it a better job because that's their clinical focus. And so I think a lot of times we sort of think, oh, well, this is just going to be an extra expense. Well, the expense is already there. Like, you're already spending by having these patients that are complex, that require multidisciplinary teams or multi-specialty care. They take up a lot of time. They make the rest of your day go long if you're not set up for it. It actually is a great way to improve the operational efficiency of the clinic by sort of concentrating that patient population into an area where it's not disruptive. So I think, in terms of how to sort of convince your administration the value of it, I think understanding these patients are always going to be there. And this is something that as OBGYNs, we have to manage and should feel, with the privilege to manage, but we also want to do it well. And so, no, I mean, it is not all administrations see it that way, but I think it's for those of us who have worked for supportive bosses or departments, it can make a huge difference. It's in our ability to do the work.
I think you touched on something super interesting, which is like the duration of it, like the early intervention. And nobody really knows the answer of like when that acute pain becomes chronic. Do you have a gestalt of that? Like, is it 6 months? Is it a year? Like, how long does it take?
I think that's such a hard question to answer because it varies per individual. Certainly. There are certainly women with endometriosis, right? Endometriosis is responsible for, in some studies, say 70, 80% of chronic pelvic pain. And when we look at it like that, there are many women who go through their entire life process, or reproductive cycle, I should say, with incredibly painful periods, and it never progresses beyond a few days of their cycle. And, obviously it would be nice for them. I mean, that's an understatement. It would be nice for them not to have to experience that pain, 2 days a month, 2 out of every 30-day cycle of their life. But a lot of people say, well, I'll just live through that. And maybe they've been told by 1 or 2 doctors or everywhere else, potentially that this isn't a problem. And so I think that when we look at that person versus the person who is 15 years old and is in my office with a horribly tight pelvic floor, urinary issues, frequency, urgency, pain with bowel movements, non-cyclic pain where they can't make it to school, it's fascinatingly different. And there is some evidence of at least that centralized pain portion of nosoplastic pain, right? This is the pain we're talking about that is more the software of the way the nerves are working rather than the sort of hardware, right? Rather than the typical nociceptive pain that we think of, like I pricked my finger, it's going to send that to my brain. It's the nerves itself. And I think that, we know that runs in families that some people are more likely to have these conditions in these chronic overlapping pain conditions like fibromyalgia, interstitial cystitis, and migraines, vulvodynia. Exactly.
That's interesting that you say that because it didn't really click for me, but I didn't realize that acetaminophen is central pain. It acts on central pain. And then ibuprofen actually is, and all the NSAIDs are more like what you're talking about, like actually addressing the inflammation. And that's why it's so effective to have the combination, So I didn't realize that, but I was like, wow. And IV Tylenol is amazingly effective. It's really expensive. I think it's like $800, and that's why we can't give it in the PACU. But yeah, it's fascinating. And I know I share a clinic with Ashley Goebbels, and so I overhear her virtual visits, and she is always talking about the crosstalk between the organs and like the central pain as well. And it just seems like it's so understudied what you're describing.
And what's shocking about it too with that is it's so complex, it's hard to study. It's very difficult to make that diagnosis, at least in a clinical sense. There are some, obviously some studies where they're able to nail that down a little easier, but that centralized pain is so much more difficult to diagnose and it's difficult to treat. I'll tell my patients often, I'll say, it's really hard. This is one of those parts of your pain that's really hard for me to prove that you have. I don't have a diagnostic test. And then it takes a while to treat. It doesn't respond to every treatment. And so it's really hard when you have something that is that hard to grasp, to, I don't want to say convince a patient, but to get buy-in for treating these issues. And I think, and a lot of the treatments we use are imperfect too, and they have side effects, and side effects are really easy to see, and a long-term benefit is harder to see.
So, we know it's complex. We know it's multifactorial. I think you've touched on some of the bigger causes, the myofascial musculoskeletal component, the endometriosis certainly, and the other non-gynecologic causes like bladder pain, bowel pain. But Amy alluded to it earlier, like the decision to surgery. Like because that's really where I want to get here today is, when do we make that decision to go to the OR? When is it beneficial for patients with chronic pelvic pain? And like what your algorithm looks like, how you get there.
Yeah, this is a great question. It certainly absolutely is important to consider, talking about diagnostic, all of the causes, right? And so if you have a patient that has, say, endometriosis and then coexisting interstitial cystitis, irritable bowel syndrome, migraine disorder, POTS, you name it, it can be hard to know where to start for sure. Many of those are non-surgical, right? And some of them are procedural interstitial cystitis, things like hydroextensions and bladder installations and these types of things. And hopefully you have a urologic colleague that you can lean on with that. So I think about endometriosis the most when you say this question, because I think that is really, we talk about 70, 80%, responsible for chronic pelvic pain.
And the other 20%, are you looking for endo and don't find it ultimately? Is that kind of always what you're looking for? I mean,
sometimes, but sometimes someone will have something that obviously does not follow the phenotype of endo, right? So when I'm looking to see if I think it's endometriosis, I'm looking for that most common phenotype. That is, I think the very most common story is, I had very painful periods from the beginning. Slowly, it may have been 1 or 2 days my period, slowly it became my entire period. Then it became a few days before, a few days after. And when you start to notice that extension from pain with periods out to being a non-cyclic pain disorder or involving other systems, then I think that's where you're thinking, okay, now we're changing into musculoskeletal, we're changing into nosoplastic causes. So even though you may already be there and have all those other things, right, it still doesn't mean you've treated the trigger, which may have been the endometriosis in the first place. And so to go back, I'm not trying to avoid your question, Mark. I know it sounds like I am. But to go back to that, when I think of when am I going to surgery, right? I think, number one, have we failed conservative management? And conservative management with endometriosis typically is some kind of hormonal therapy. Failure may look like there's still pain. Failure may look like, the patient cannot tolerate the other treatments. And I think, very commonly, I think of with endometriosis, when I think of medical management of endometriosis, I think of there's two main goals. The one goal is stop the trigger. So you may have endometriosis throughout the pelvis. I think of dried tinder on the bottom of the forest floor, right? But if I never drop a match on it, you may never have pain from it. And so the match is when the progesterone drops and your period starts. That is the match. And that's the trigger. So if we can stop that trigger, we can oftentimes stop that pain. The second portion of this is, if we can hold us in the luteal phase as opposed to the follicular phase of the cycle, in the follicular phase when you have the most endometrial growth. And the endometrial growth is more or less stabilized in the luteal phase, right? In day 14 to 28. So if we can keep ourselves in that phase, which is essentially what a birth control does, estrogen or progesterone, everything, any contraceptive with the exception of an IUD, right? Because IUDs in maybe a small percent do stop the cycle, but not completely. So if you fail medical management through hormonal therapy or the other therapies we're doing, pelvic floor physical therapy, treating the other issues, that's one time when I think. The other indication I see often is someone will say, I'm doing great. My periods have stopped. I have no pain, but when I have sex, when I have deep penetrative sex, it hits a spot and I just can't. And that's oftentimes because, endometriosis lesions tend to be tender in and of themselves, right? And so if you have a deep infiltrating nodule at the back of the vagina and every time they have sex, it hits, a lot of times that won't be treated by medical management or physical therapy. The other time is when we're looking at endometriomas, right? They oftentimes present the same way where they're painful on intercourse. But when we look at an endometrioma and it's hurting when someone's bending or moving or when they have sex or when they're trying to get pregnant, those are another time when surgical treatment becomes necessary and actually removing those cysts. Now, lastly, I think about fertility. And there are two instances during fertility that I think that can be really beneficial. One is typically when someone is considering in vitro, I often have them talk to their reproductive endocrinologist about that, to think whether they think removing endometriosis can be helpful in this situation. Sometimes, there's just a lot of mixed data on that now, and I want to have them on my side when we make that decision. There certainly is, I think, some benefit. I think we're seeing that more and more with deep infiltrating endometriosis with endometriomas. There's certainly some benefit to surgery for fertility, even with IVF. But without IVF, we definitely see a benefit. And, it's not enormous. It's about an 18% relative risk increase, improvement in fertility, but it certainly helps. And I've certainly seen that help.
Is that improvement across all patients? Because I remember I gave a talk recently to the reproductive endocrinology fellows in Cincinnati. And so I had to do a ton of homework to, that's how I learned about something is what I'm asked to give a talk on it. But most of what I read more recently was unless there's specifically tubal disease, unless you have occluded tubes and you're not doing IVF, the data is not super strong on the benefit of, we know endometriosis is associated with infertility, but does endometriosis surgery improve fertility? And you're saying the answer is yes.
And I would say with an 18% relative increase, right, that's not huge. And so I completely agree with what you're saying, Mark, is that you're not necessarily, it's not a huge increase, but those numbers are from sort of one of the, there's not a whole lot of these randomized controlled trials, right? But the EndoCan trial, right, that looking at endometriosis and fertility in Canada, and that was where those numbers are from, the 18%. And I think you're absolutely right, though. I think it's not a huge increase, and I don't think, the other reason that I'll look into related to fertility is if someone's in just too much pain to try to conceive naturally, right? And so that where either pain with intercourse or pain in general, and to go through periods. And so sometimes then we'll do endometriosis to improve their pain scores as far as, in terms of dysmenorrhea and non-cyclic pelvic pain, dyschezia, that sort of thing.
Wait, so I'm confused. So do you do fertility? Do you do endometrioma surgery for fertility patients or no?
So during IVF, if the cysts are large enough where it's going to impede the retrieval, then yes, for endometriomas.
Most of the time they're saying now, or at least what I read most recently was, I thought it was like endometrioma is 5 centimeters or less. A lot of the IVF docs, if they can reach the ovary, will say don't, because the risk of injury to the ovary and the ovarian reserve is impacted in a way that is not helpful. It used to be, there's an endometrioma and they're going to get IVF, get out of the way. Now most REIs are saying, leave them alone. Like we can do the retrievals, leave the endometriomas there, because otherwise you're just ripping follicles out by taking those endometriomas out. Is that, what do you think about endometrioma removal specifically as it relates to fertility?
Specifically, the data we have so in IVF, absolutely. And that's why I always reach out to REI first, especially, even with endometriomas, right? And so,
and I'm the same way. When your REI tells me to operate, I'll operate for fertility. Otherwise, I like to have a partner in that game. No, I'm with you 100%, Mark.
Now, I do think if someone is not in a position to do IVF, and they've been subfertile, they've demonstrated themselves subfertile, then I do think removing endometriomas. Now, if it's a 1 centimeter endometrioma, is that going to improve their fertility? I think it's tough to say. And I tell them, I don't think we know. But I do think it can, certainly improve fertility when we're talking about, even albeit not by large numbers, but it can improve their fertility by removing endometrioma, certainly.
Well, it's good to know, because I think a lot of people, like those who live in Kentucky, don't have a state mandate that requires insurance coverage for infertility services. And so if you have painful periods and infertility, you can get an endometriosis surgery covered, indicated because you're symptomatic. That may improve your fertility. That's a pretty powerful thing when your only other option is something that's maybe financially difficult or impossible. So yeah, I think it's important to understand what our options are as surgeons and where we can help out. Where do they think the improvement from fertility comes from? Is it just decreased inflammation? And when you say endometriosis surgery, so we've talked about endometriomas, but are you doing huge peritoneal resections? Are you just going after specific lesions? Because I think there's a few different schools of thought in our world about how to treat endometriosis. Is it just restore anatomy, get deep infiltrating endometriosis nodules out of the way, and you're never going to get it all. That's just it's impossible. Some people will claim they can, but what's your approach to endometriosis surgery? And has it evolved since you left Louisville?
I think my approach is generally resective, is to resect those lesions of endometriosis, all of them what we can. Certainly we have to balance between, how radical our surgery is and what the risk to a patient is, right? And I think whenever we're involving deep infiltrating endometriosis, when it is invading other organ spaces through and through the diaphragm, the bladder, the bowel, the ureters, all those things that can really be long-term. I think we need to pump the brakes a little bit and say, how radical do we need to be, especially given there is evidence of hormonal therapy and efficacy in treating these. There was a, and I'm trying to remember where the study was out of, it'll come to me, but there was an MRI study that looked at treatment with Dienogest, which is a sort of progestin only available in Europe. It's probably most analogous to norethindrone acetate here in the States. And they looked at endometriosis nodules followed by MRI, and they found that 53% of bowel lesions shrunk greater than 10% with norethindrone acetate. They found that 35% stayed the same, meaning did not change by greater than 10% up or down. And the remaining 12% grew, regardless of being on norethindrone acetate. So there's medical treatment that does work for deep infiltrating endometriosis. Deep infiltrating endometriosis, despite sometimes what we say about, the amount of endometriosis does not determine the pain. I think it doesn't absolutely determine pain, but there certainly is evidence of posterior disease, deep disease being more painful than superficial. I think we don't control well for the pelvic floor and the nosoplastic pain that goes with it. And I think that's a big problem in us determining that pain. But I certainly think that we don't need to be fully radical in resecting everything. However, on the contrary, we have studies that look at resection of endometriosis versus ablation of endometriosis. And some of those studies show that there is a benefit in non-cyclic pain, dyspareunia, dyschezia, when we're looking at endometriosis and resection. Now, out of Cleveland, so one of your neighbors, Dr. Flicht, a former colleague of ours at the Cleveland Clinic, she's now at University Hospitals in Cleveland, and they did a study looking at superficial endometriosis and looking at resection versus ablation. And it was a randomized controlled trial, and they found no difference. And so I think, we really do need to consider that superficial endometriosis, that evidence probably isn't as stark as when we're thinking about resecting deep infiltrating nodules and removing endometriomas, just due to the severity of that disease and fibrosis, associated fibrosis, co-localized neural growth. I think we have to be careful about labeling, do we only do resection? Do we only do ablation? Because I think there is benefits to resection, but I also think we can overplay saying that's the only way to do it.
The other piece that we talked to Keith Isaacson about was about adenomyosis, right? So you have deep dyspareunia, central pain, dysmenorrhea. Why would a few superficial endometriosis lesions cause that pain? Likely there's some, the incidence of adenomyosis is almost certainly much higher than we report it, especially in younger patients. We used to think it was a disease kind of women who've had kids, and now we find it much more frequently when we look in women who've not. And so I think there's a huge component that we overlook as well. But so resection over ablation in general, endometrioma is removed in general. I mean, obviously these are all after long discussions with patients and counseling and risks and those things. But for endometriosis surgeries, are you always recommending hormonal suppression afterwards as well? Because I have a lot of patients that I'll see, they got resections 3 to 5 years ago. Okay, what do you want now? No one ever told me to be on anything. Is that one of those things you always recommend if you feel like you got it, all the visible disease? I mean, what's your discussion on hormonal suppression after endometriosis surgery?
One of the more important conversations that we have regarding all of this is that I think that treatment post-surgically is very important. And I think we have plenty of trials to back that up, that talk about recurrence of growth of, I talked about the MRI of the endometriosis, that study, but also looking at recurrence of endometriomas. And, it's harder to see the superficial endometriosis, right? Because we can't just stick a scope in someone every week and look, and we can't see it well with imaging. But when we look at resection and we look at post-op, we look at recurrence of pain symptoms, I think that it's pretty well established that those are going to help you stay out of the OR longer, and they're going to help you to keep your pain scores down longer. The exception, of course, is when I talk to the patient, I say, look, all of this is your quality of life. Your pain is important. Your endometriosis is important, but this is really all quality of life. None of this is going to kill you. And so if I give you a birth control pill and you're absolutely miserable on it, is it worth it? Like, is it worth it to suppress this endometriosis, or would you rather just come to the OR again in 5 years? And there's increased risk when you do, potentially, but it's all about quality of life. And that's a discussion I have. And I say, look, if you weren't a person, if you were a population, as a population, absolutely you should be on suppressive therapy. And the studies also show, just talking about that therapy, that whenever we try to give therapy for 6 months afterwards, that does absolutely nothing. I mean, it works for 6 months. It works. Our medical therapy works when you take it. I talk about the example I give my patients. I say, look, this is like when we give you hormonal therapy, your endometriosis is like grass in the winter. It is not growing. It's just sitting under the snowpack and it's not doing anything. And you don't have to go out and mow it. You don't have to dump fertilizer on it. It's just there. And that's the way I think of as medical treatment. It is suppressing growth, but it's not cytoreductive, right? It doesn't destroy the lesions. But as long as you're on it, as long as it's winter, it should be suppressing your symptoms.
I think that the endo warriors of the world would be, aghast at your recommendations, because I know that some of them are very much like, you need to operate on me again. And like people are like, no, I don't want to operate on you again. Like, I might have to, but let's do what we can to avoid this situation. It's so weird how we've gotten here. This is what my colleagues tell me. Thankfully, this is not my wheelhouse. Thank you so much. But anyway, I think that it is super interesting. It's my former fellow Jocelyn is at Pittsburgh now, Jocelyn Fitzgerald, and she's always making the point, like, if this were cancer and we had the resources of cancer, researchers, like you're talking about cytoreduction and all these different things, like if we knew all this tumor suppression kind of stuff for endo, it would be like a game changer. I mean, because there's I think things are changing in terms of scientific research and funding, but historically it hasn't been there on that like basic science front. So it's just a really interesting point that you bring up. I also want to bring up another medical therapy that right now is kind of a struggle to get covered, is like the pelvic floor Botox, and so how do you get it covered? What's your technique? And when do you know that this patient is, like, I saw a patient today and I was like, this lady is pelvic floor, 6 weeks of pelvic floor PT, even a year of pelvic floor PT. I don't know if she's going to ever get there. So I just was like, I think we need to talk about pelvic floor Botox now and work towards that goal. Like, what is your sense of it? You know what I mean?
I am a strong proponent of the pelvic floor PT, yes, but of pelvic floor Botox as well. I think it is a challenge sometimes to get it covered. I think there's been certainly a mix of studies that aren't necessarily obviously supportive. And, some of the data is mixed. I think one of our best randomized controlled trials said, yeah, there was a decrease in pain at 4 and 12 weeks, but it was non-significant. There was not enough in that trial to prove it. And so, I think insurance companies jumping behind that based on that data has been difficult. There are other smaller trials that show improvements in muscular tone, show improvements in dyschezia, dyspareunia, non-cyclic pelvic pain, dysmenorrhea, the whole 9 yards, but they're smaller and they're not randomized. And so I think more trials are necessary for it. However, clinically, it is a really tough problem because there's not tons of treatments. When we talk about treating pelvic floor tension myalgia, the pelvic floor physical therapy absolutely is number one, and that is the mainstay. But when it's not working, then what? One of the very easy answers to that, and this is, I'm always a little surprised, is to treat the trigger first, right? Like, look for the other triggers. Do they have endometriosis? Are they 3 steps forward, 2 steps back every month? And then all the rest, right? So look for the triggers.
I have that conversation with my patients a lot, where the analogy is like, if you hold a gallon of milk for like a week and I take the milk away, your arm's going to be like spastic. That bicep muscle is going to be trashed. you'll have to stretch it and work on it. If you hold it for a year, it's going to take some extra work. But if you don't take away that initial insult, so yeah, like endometriosis can be associated with musculoskeletal pain, taking away the endometriosis or treating it or suppressing it doesn't mean you don't have that leftover pain. And so like, and the other thing's true, if you keep treating the muscle pain without taking away that gallon of milk that you're holding, it's always going to be there. So it's not it's not a one or the other kind of discussion. We have to look at this holistically and understand how it's all related. It's all in a continuum and how one can be associated with the other. And we have to kind of look at all of it. So I think that's a great point you make, that it is, yes, you have musculoskeletal pain, but are there triggers? Are there things that are leading this, when someone's going to punch you in the stomach, you're going to flex and tense up, right? So why would you be surprised if people's pelvic floors are just tense when intercourse is painful? They're bracing themselves. I mean, for years.
That's funny that you use that analogy about punching in, because that's the analogy I use every time. I also, I love that milk jug analogy too. That's great. I'm going to steal that from you. The other one that I use is I say, like you've been suffering from endometriosis for maybe 30 years. And, in World War II, after they stopped bombing London, it was like a better place to live, but not a good place to live. Because there was like no grocery store, no electricity, no running water. There's nothing. It's a pile of rubble, right? And that's sort of similar, is that a lot of people will be given a birth control. And I think this is a problem in the way we've learned this to be able to counsel our patients, is a lot of people will give birth control for endometriosis and they'll say, well, that didn't work. I still have a lot of pain. And of course you do, because we haven't fixed any of the other things that have gone wrong. And so I think that is one of the reasons when we talk about birth controls is why people have been convinced that birth control is ineffective, because it is an incomplete treatment. One of the analogies I use about that too is I say, if you have 5 toddlers asleep in a room and you go and shake one of them awake, well, that toddler's going to start screaming, and then all the 4 wake up. All the rest of them wake up. When you put that one toddler back to sleep, they're not going back to sleep because you got 4 other screaming toddlers, right? And so you have to treat all of these at the same time, but it goes against everything we've ever learned about the scientific method. Well, what if I give you 5 things at one time? How am I going to know what worked? But we have to, because all of these things exacerbate all the other things.
Well, also for me, I will tell you, as a urogynecologist, when Botox came out for idiopathic overactive bladder and urge incontinence, thank God, because when we were putting in slings and they just had stress incontinence, and then you gave them another problem with the urge that bothered them more, it was crazy. And then we do rectus repair, and then they have de novo dyspareunia, and you send it to pelvic floor PT, and then it doesn't help them. At least now with pelvic floor Botox, I mean, knock on wood, if their insurance covers it, there's a little bit more of a rescue. But it's like not having these tools in your toolbox for problems that are known sequelae for surgeries that you do. It's a terrible feeling to have this problem after surgery that they didn't have before. Do you know what I mean? So maybe it doesn't work for everybody, but it definitely clinically works for a lot of people. And then sometimes you just get it to that point, and I mean, maybe you can stop doing it after you get them to a point where it's not like this crazy stimulus. But that substance P, that pain cycle, it's hard to get around. The itch, scratch, itch, it is really hard. Once you get a cycle going like that in the body, it is not pretty. We need a Dupixent for the endo or all the substance P or whatever.
Yes,
I'm on Dupixent. I love it. It's amazing. It's IL-4 and IL-6 inhibitor. I wonder if it helps endo. I don't know, but do you know what I'm saying? It really helps with the cytokine release.
Well, it's a chronic pelvic inflammatory disease, right? Well, we don't know what it is. Similar to IBS, IC, right? It's just these kind of chronic pelvic inflammatory conditions of unknown etiology. And I tell patients, if you treat endometriosis, sometimes the other stuff gets better, because when endo flares up, it's pissing off the neighbors. I mean, it's just inflammation. There's just something there that's bigger. But to get back to surgery, I want to hear from Mark what you think about the hysterectomy, oophorectomy for for pelvic pain, like when that's a trigger you pull, when that's a discussion you begin. Because some patients are like, I want a hysterectomy, don't talk to me about anything else. And there are patients that like, talk to me about anything else but hysterectomy. How does that fall into your armamentarium? Because it's not a cure for endometriosis, right? But it certainly has its role in surgical management of chronic pelvic pain.
Yeah, for sure. I mean, to pick off the easy part of that topic, right? If they have a severe adenomyosis is not controlled medically, that's my favorite, right? With no coexisting endometriosis, then you just cure it. And that's wonderful. So I think looking for those things, I think, sometimes the diagnosis of adenomyosis can be a little bit difficult in that we're not necessarily seeing it on all the imaging. The other thing is not to necessarily, all radiologists don't look for it that hard, not always. And in your center, if you notice that no one ever says adenomyosis, it's worth familiarizing yourselves with those findings and then reaching out and saying, hey, what do you guys think about, documenting adenomyotic findings more often? And I think, that's one thing from a larger medical system that I see as being an issue.
I think the same is probably true with adenomyosis in pathology. Like, they're not always looking for it. Actually, do me a favor, take a few more slices. Its prevalence is probably, what are they really cutting the muscle for, right? Like, what are we looking for? If there's something there, the same way they were doing with their tubal slices for salpingectomies and finding pre-malignant disease there, my guess is, and I feel like I've read this before, that oftentimes if you take more slices, you find more adeno.
I also feel like I read that before, but I couldn't tell you where. But yeah.
We had a Keith Isaacs and we had a grand rounds on this. Tom Gallant, who's now at Beth Israel, and he said the same thing. There's a study on it. Yeah.
Excellent.
You guys were right.
Amy Park for the win.
Yeah.
So so by that, I think uterine tenderness, right? If someone is like, if you do an exam and their uterus is super tender, they have pain with intercourse and nothing else has solved it and they're ready for a hysterectomy, I think that's a really good indication.
Those are the happiest patients. My patients with adenomyosis, oh my gosh, you do a hysterectomy on them, they're so happy. So happy, like 10 out of 10. I love that. It's like, that's like probably your easiest patients, guys.
Absolutely.
The ones who've had endometrioma ablations with adeno.
Oh.
Yes.
OTD with that uterus. Let's go.
Yes.
Done.
And so happy and just
so
cured,
happy.
Right? Immediately.
Yeah.
But where it gets more difficult, right, is when you talk about in endometriosis per se. I think that one of my goals medically in endometriosis is to develop amenorrhea, right? And that's been shown over and over that overall pain scores are better when we do that. When we're not able to do that in endometriosis, I think then the next time we're in there doing a resection of endometriosis, or primarily we think about, well, let's take the uterus out because it's not going to bleed. I try other things, an IUD with concomitant, systemic therapy, but oftentimes in those situations, absolutely refractory to bleeding and the bleeding is painful with endometriosis, I think can absolutely be helpful. Sometimes in deep infiltrating endometriosis, when it is significantly on the uterosacral ligaments and around the ureters and around all these areas, it can make it a lot easier to fully resect all that disease. Don't get me wrong, that I think, I've done plenty of resections where we spare the uterine artery. Sometimes, man, it can be really hard when it's all around the uterine artery and the ureter. And, and that can decrease the risk of that surgery when you can go out laterally to the ureter, more like a, modified, Wertheim hysterectomy and get it at the source, next to the, the bifurcation of the uterine artery from the internal iliac, I think that can make it much easier to resect all that disease. And then I think there's something I certainly don't understand. There's a lot of things I don't understand about chronic pelvic pain, but I also think a lot of women, even with non-cyclic pain, their symptoms will improve significantly when we take out when we take out the uterus. And we know, there is a really old, I don't say really old, but an aging trial. Harry Rich's trial looked at hysterectomy with endometriosis and said, there's definitely a benefit here. And I definitely see that. I don't think it's a reason to remove everyone's uterus, but I do think it can be helpful when everything else has been refractory to treatment.
I mean, one of the studies we used, looking at just all causes of pelvic pain, I think 70% of patients with pelvic pain, regardless of diagnosis, improved with endometriosis with hysterectomy. 20% no difference, and about 10% got worse. So we don't always know why, but it does seem to help, and for a big chunk of patients. Certainly, it's better to have some a little more specific data than that. But that's something I remember from that's been a few years, but that was sort of how we cancel patients.
Yeah, no, I think that's what's so difficult sometimes about pelvic pain is, you talked about indications. I always struggle with the patient who I don't know if doing this surgery is really going to help. I think there's other causes, pelvic floor, bladder issues, bowel issues that I think may be more pressing, but they really want to explore that and they sort of can't. You don't feel like they can move forward until we do that surgery. And I've, really counsel quite a bit about, hey, I don't know if this is going to work, but I do think that sometimes that helps patients to get past it, especially when you've identified other issues. If it doesn't help, then they're ready to do the others. And then a lot of times it helps. And I tell patients that, I'm humble enough to recognize that sometimes I don't think it's going to help, and it does, and it helps a lot. And sorry, I didn't recognize that.
But you listened and you did it, and that's fine. You don't always have to have the same exact thing, but that's part of the patient-physician relationship. So,
yeah, absolutely.
Last question for you as we're getting close to the end here. Unless Amy's got more, but my last question is, I know you did residency with Hypner, but I feel like in AGO, we go to one room and it's nerve ablation for pelvic pain, and then the next room is like, oh, look, we spared the nerves. Which is are we ablating nerves, or are we sparing nerves? What do you, in your practice, what are you doing surgically for these refractory chronic pelvic pain patients, these nerve ablation surgeries? Are you doing any of that stuff, and what's your feeling on that?
I don't do a lot of nerve destructive, well, at least intentionally, neural destructive procedures.
These magical hands have never once touched a nerve, right?
That's right. I think when we, I haven't seen a lot of advantage. I've done presacral neurectomies. I don't tend to see that my patients do much better after presacral neurectomy. I think, with a presacral neurectomy, right, I think you want to look for a more central pain, right? That's what you're treating with presacral neurectomy, but I haven't seen huge advantages. I know there's other surgeons I've talked to who feel like they have more advantage from that. I worry about the side effects of presacral neurectomies with, taking away some of the sympathetic innervation of the bowel and the bladder. But, that being said, I don't think it's, in patients that I've seen with presacral neurectomies as well, I don't see that number as being incredibly high. Some of the, and I can't remember off the top of my head, some of the numbers from your trials of presacral neurectomies, it's not super high that they have these issues, that they have these bowel bladder issues. But I'm always afraid of something that I don't know is going to be very effective, and then leading into, possible worsening of side effects. So I'm not a huge presacral neurectomy fan. The Luna procedure is fun to talk about, laparoscopic uterosacral nerve ablation. That's been pretty roundly shown in multiple trials to be pretty ineffective. That's right. That's where you ablate just the top of the uterosacral nerve in the hopes of it's sort of like a downstream presacral neurectomy. It's those nerve roots at the inferior hypogastric plexus that come together as a hypogastric nerve, and then, for lack of a better word, they replexate down in the pelvis near the uterosacral ligament. But you just don't get enough of it with Luna, I don't think.
I've seen that famous video where they do a Luna and they just blaze right into the ureter.
Oh, yeah.
Have you seen that video? Laser the ureter one? Oh, yeah.
Oh.
Oh.
Do you
we have to end
ever,
on something else, Amy. Go ahead.
yeah, do you ever start people on like the central modulators like tricyclic antidepressants and the gabapentin and Cymbalta and things like that?
Yes, I use all of those: amitriptyline, Cymbalta, gabapentin, Lyrica, or pregabalin. I guess I should use the generic, but so I do use all those, and I don't start with them for everyone though. I don't. I do think in refractory pelvic floor, I think there's a nosoplastic component sometimes to that being refractory, and so I'll explore those options. Certainly with vulvodynia, right? I love gabapentin as a post-op treatment. I give a lot of my patients 300 milligrams TID gabapentin to take with their, oxycodone and ibuprofen and Tylenol post-op. And I think a lot of patients that really helps. Some of them recognize it's a long-term thing that they want to take for pain, and it, decreases the amount of opioid use as well. So I've used that a lot, but and then to get back to, we talk about neural ablation is, I think it's just so very rare that you can cut or ablate a nerve and it will sort of, the last thing you want for it to do is grow back damaged, right? And so that is a big concern. And I'm always a little afraid about that and I think the efficacy, and I couldn't quote trials on this, but talking to I work with someone who does an interventional anesthesiologist, and he just tells these ablative procedures, especially like pudendal ablative procedures, don't have a lot of benefit. They just don't tend to work.
It's kind of like lysis of adhesions when you talk to a general surgeon. They're just like, yeah, it'd be nice to have some anatomic thing we could address to say this is we can take this thing out or whatever. But the reality is it's sadly often not that simple. But well, I feel like we could go all night. This is complex, Mark. I appreciate you, but I'm sure your patients out there are very, very, very excited to have you out there doing what you do, doing those complex surgeries, taking care of their chronic pelvic pain. Need more people like you, but also we just really like you and like hanging out with you. And it was a pleasure to have you on. So it was great to see you. Love that you stuck with the long hair as a former, I used to have long hair back when I had hair, like way back when in high school.
You could do a comb over.
Just like the back to forward.
The sad thing about me is I got this long hair, but it's wasted on someone who can't surf and can't play an instrument. So it's...
Yeah, I'm sure. And people like get you to a party and hand you a guitar and they're just like, oh, like realize it's nothing happening. But you know what? You're owning it, man. And that's what makes you you. That's great. It's always good to see you. Thanks for coming on, and look forward to seeing you at our probably AGL for me. Hopefully next time I'll see you.
100%. Yeah, I'll see you there.
Well, thanks, Dassel.
Pleasure to hang out with both of y'all. And thank you for giving me a chance. I do have a soapbox when it comes to chronic pelvic pain. I love to stand on it and yell from the mountains.
Well, no, your patients are very grateful, I'm sure, so, as are we all. So happy to be your soapbox.
Thanks so much. Good to see both y'all too.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Overjinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.